It's a great pleasure to introduce one of my colleagues, Dr. Akilesh GOKUL, who's a vision scientist from the University of Auckland. Aki is an international expert on collagen cross-linking, keratoconus, and contact lenses, and today he's going to talk about contact lenses.
Thank you for the introduction, Charles. So my name's Aki. I'm a senior lecturer at the University of Auckland, and as Charles mentioned, a practicing optometrist specializing in contact lenses. So we're speaking about, in this session on trauma, how contact lenses can be used in management of ocular trauma. I have no financial disclosures. So contact lenses are indicated essentially following primary repair or secondary repair from a traumatic event. It can be used to provide visual rehabilitation without the requirement of further surgery, or it can delay further surgery so that the patient can function while they recover to a point where they can have an additional operation to restore vision without the use of a contact lens. Of course, in cases of trauma, you can have unforeseen complications during secondary repairs and things like that. Sympathetic ophthalmia is always a risk, and also we want to prevent or delay the need of corneal transplantation since it's associated with much morbidity. Blunt force trauma or bursting type injuries, the primary repair can cause corneal irregularity, and it can also damage the iris and the lens itself, so the trauma itself. The repair can result in an iris defect with enlarged pupil. It can also have the lens damage. These patients can be left aphakic with a high refractive error, and of course, IOL calculations are difficult in these patients. They can be left with a high amount of anisometropia or antimetropia. Penetrating eye injuries depends where the penetration occurs, whether it's through the cornea or the conjunctiva, but the net result is the same. The primary repair can result in corneal irregularity and damage the iris, and iris or lens itself can result in aphakia and iris defects as well. Of course, the retina must be intact in order for a contact lens to function properly. There are many types of contact lenses available in the modern world. Soft contact lenses are the most commonly typed use of contact lens for the correction of ametropia. These can range from daily disposables to fortnightlies, monthlies, and custom contact lenses as well. These can have artificial irises or a colored contact lens. Hard contact lenses or rigid contact lenses also have a wide array of different lenses available to us, ranging from an RGP, a small hard contact lens, all the way to a large scleral contact lens. So first of all, looking at how we can address corneal irregularity following trauma. This is done with a rigid contact lens, so it's important to understand how this works. So of course, the rigid contact lens remains its own shape on the eye, maintains its shape. The fluid or tear film layer behind the contact lens effectively fills in the irregularity. So the hard contact lens acts as a mask, effectively creating a new front surface for the eye, and hence the eye can function like a normal eye once again. Depending on the level of irregularity, we should consider different options. If it's a mildly irregular cornea, you can use spectacles or a soft contact lens if the vision achieved is better than 6/12. If there's moderate irregularity, we should consider things like RGPs or small hard contact lenses, but you can consider the whole gamut of contact lens options available. Effectively, what we need is to look at sagittal heights. That's how much irregularity a contact lens can correct. So an RGP being a small lens can only have a small sagittal height, so it can only correct mild irregularity. More severe irregularities need effectively bigger contact lenses, which have a bigger sagittal height, which can then correct for the irregularity. We'll go through a few cases of patients that had irregular corneas following trauma and how these were managed. So we have a 40-year-old male. When he was younger, a packaging strap snapped and it penetrated his cornea of the left eye, damaging the iris and lens as well. The primary repair encompassed just suturing the cornea back together. We can see in the image there, there's a suture that remains within the cornea many years later. It's well buried, so it didn't need to be removed. The secondary repair included a phocoemulsification and intraocular IOL, intracapsular IOL. The iris damage was minimal, so no further repair was required. So look at the patient's spectacle refraction. We can see the right eye, the undamaged eye, corrects very well, 6/6 with a moderate amount of myopia there. But the left eye only corrects to 6/12 because of the corneal irregularities. In this case, the main limitation to the patient's vision is the irregular cornea. So healthy retina and a clear IOL. So we look at the patient there clinically, we can see that there is a slightly distorted pupil shape, but it looks fairly good overall, still responds to light. We can see that the trauma repair was down the bottom here. The astigmatism looks fairly regular when you overlay the topography over the iris image, and you can see the iris atrophy there on the temporal side where the injury occurred. In this case, the patient was fitted with a rigid contact lens, an RGP, a small contact lens of 9.5 millimeters in diameter, small refractive error there, and correct the patient up to 6/6. So high utility in this patient who would otherwise be left visually impaired in this eye. Case number 2 is for corneal laceration. Once again, this is an 80-year-old male, had a non-penetrating corneal injury in childhood that was repaired, but is left with poor vision through the rest of his life. In his later years, he underwent age-related cataract surgery, but the poor vision persisted as the cornea was distorted. So clinically here we can see from his refraction, his left eye, the good eye, corrects that very well with a small amount of myopia, but the right eye, despite a high level of astigmatic correction, was poor vision at only 6/18. And as you can see from his corneal tomography, he's got a lot of irregularity in his cornea. This is a moderate amount of irregularity. So the main issue here was the irregularity once again. And once again, we can see here from the clinical image here the scar through the center of the cornea where the injury occurred. And you can see that results in an irregular cornea over the pupil. In this case, the patient was fitted with a semi-scleral contact lens, a big, hard contact lens. This was chosen because of the level of irregularity, but also the level of comfort. These tend to be much more comfortable than the small lenses, and is able to restore visual function fantastically. As you can see, this patient was 6/7.5 with this lens in place. So moving on to addressing anisometropia or antimetropia when there's an iris defect as well following trauma. We usually use a soft contact lens for this. The cornea usually remains a regular shape, so you can use a soft contact lens. They have a large power range in the modern world. Theoretically, any sphere still can be corrected with a custom-made soft contact lens. The colored contact lenses have an artificial iris. You can have the standard ones, which are available for cosmetic purposes, but they work quite well for these patients as well. They're more comfortable because they're a lens that was replaced more frequently, either daily or monthly. But you can get a custom contact lens, which is almost exclusively for iris defects. They have a black backing to them, so they control glare much better than the standard cosmetic contact lenses because they have a clear backing to them. These are less comfortable. They are replaced only every 6 to 12 months, so the material is more stiff effectively, making it less comfortable for patients to wear. So case number 3 here is a penetrating eye injury once again. This was through the cornea. A 29-year-old male had a metal foreign body go through his cornea, damaging the iris and lens as well. So the primary repair was just that of suturing the cornea back together. Secondary repair was more extensive. There's a corneal wound revision, phaco, and this patient was left aphakic in this case. They did not put an intraocular lens in to start with, and there was a vitrectomy performed as well. As you can see, it's quite a complex case. You also end up with secondary ocular hypertension from the trauma. So we'll look at his case. Spectacle refraction-wise, you can see his left eye has almost no refractive error. It's emmetropic, whereas right eye is very hyperopic with a bit of astigmatism resulting from the aphakia and also the primary repair. Fortunately, you can see that his cornea is quite regular. The primary repair left him with a moderate amount of against the rule astigmatism, but it corrected up very well with the spectacle refraction. Of course, this is not practical, so the patient did need a contact lens in the end. Interestingly, it was not very photophobic, despite having a very large iris defect. So clinically here we can see that it has a very big iris defect here, very large pupil, and its primary repair was located temporarily here on the right side. And when you overlay the topography once again, you can see that as a very regular topography, so a soft contact lens can work for this patient. So in his case, we went for a clear custom-made soft contact lens with a very high refractive power included, which corrected his vision up perfectly. So we did not use a colored contact lens in this case because he didn't need it. He didn't have very much photophobia, fortunately. Case number 4 is once again a penetrating eye injury. This time it was not through the cornea. A high-pressure hole struck the patient in the eye. It's a bursting type injury near the limbus. Damaged the iris and lens as well, but not the cornea directly. So the primary repair was to re-establish globe integrity and also removal of the damaged part of the iris and phacoemulsification and an IOL as well. So this person, fortunately, had a relatively regular cornea, despite it looking quite irregular there. We'll see in a second the part it looks through is quite regular. So he had high amount of anisometropia, which is the main limitation to his vision, as well as the extreme amount of photophobia due to the large iris defect. So as you can see there, through the center of his pupil, his vision is quite good because his astigmatism is quite regular. In his case, we used a standard colored soft contact lens over-the-counter type deal, and as you can see, it's clear there, but it provided significant improvements to his photophobia and corrected his vision to 6/7.5. Final case here is another interesting case with penetrating injury through this conjunctival sclera, 59-year-old male with a bungee cord damaging his eye. Primary repair encompassed re-establishing globe integrity, but he was left aphakic once again. So he had, again, a very regular cornea, but he had a high refractive error. You can see the left eye there was +11 with a -2 astigmatism. Extreme photophobia once again due to the very large iris defect. But the minimum amount of corneal irregularity through the center there meant he could use a soft contact lens. So he was fitted with a custom soft contact lens, which has a black backing to it, which dealt with the refractive error much better, but also the photophobia as well. So in his case, 6.7.5 once again. In this case, the patient wore the lens for about 2 years, then underwent a secondary surgery, which included a sutured IOL and a sutured artificial iris implant. His refractive area still ended up quite anisotropic, so he's back in soft contact lenses ultimately, but these were standard soft contact lenses. So in summary, contact lenses are very effective at restoring visual function post-surgical repair or healing from ocular trauma, so should be considered where possible because it is a very conservative approach and allows the patient to function normally. They can be used long-term as the primary form of visual correction or as an interim measure while waiting for the eye to heal or settle before having a secondary or tertiary surgery performed. Widget contact lenses are highly useful in patients that have corneal irregularity, and they can prevent or delay corneal transplantation altogether. Soft contact lenses are highly effective at addressing anisometropia when there's minimal corneal irregularity, and they can have an artificial iris as well when there's an iris defect, which can be excellent at addressing photophobia. Thank you for your attention. I'd like to acknowledge my mentors as well as the contact lens manufacturer in New Zealand who provides these contact lenses. Thank you very much.